Okay, good afternoon, everybody. My name is Carol Rogan, and I'm Scientific Project Manager for Dementia Research Network Ireland. And you're all very welcome to this afternoon's forum on gender and dementia care aspects in family caring, which we're hosting with the National Dementia Office. And I'd just like to say thank you to Engaging Dementia for hosting us as part of their annual conference. So we'll be recording the session today, and the recording will be available in about 2 weeks' time on our YouTube channel, and also Engaging Dementia will be able to send you links to the recordings. We'll also be producing a report of proceedings, so we'll be disseminating that when that is ready. So you'll see the programme there. The format for the next hour and a half is we're going to start off with Jeanette Dwyer from the HSE talking about National Dementia Care Policy. Then we'll hear from a number of speakers on the family care landscape for dementia through a gender lens. And then we'll finish with a panel discussion, which is on the LGBTQI+ community and dementia care. So I'll hand you over now to our first speaker, who's Jeanette Dwyer, Assistant National Director, Services for Older Persons and Dementia Care in the HSE.
Hiya, thank you. I'm just having a bit of difficulty trying to get the video started. So I'm delighted to be given an opportunity to open the second Policy and Practice Forum, which, as mentioned, has been co-hosted by the HSE National Dementia Office and Dementia Research Network Ireland. So this year, the focus of the forum, as you know, is on the gendered nature of dementia caregiving and the key considerations kind of related to female carers in the population, the invisibility of male family carers, and the emerging issues relating to people who are at part of the LGBT community and dementia family caring. So we know in Ireland there's over 64,000 people living with dementia. It's expected to rise to over 150,000 by 2045 if our current trends that we're seeing continue. Dementia has physical, psychological, social and economic impacts, not only for people living with dementia, but also for their carers, families and society at large. We know it's just not a condition experienced by older people, and there are approximately around 4,000 people that are aged under 65 years that are living with dementia. And dementia is currently the 7th leading cause of death among all diseases, and one of the major causes of disability and dependency among older people globally. We're learning more and more every day around the risks, and within the population there are groups of higher risks. For example, there's about 85% of dementia among people aged 55 that are living with an intellectual disability. So there are key issues that we need to address nationally, and one of them is to improve the rates of diagnosis, with just over 40% of people with dementia receiving a diagnosis. So there's often a lack of awareness and understanding of dementia, which results in stigmatization and barriers to diagnostics and care. Dementia Understand Together is a key national awareness programme, and that's around trying to tackle the stigma around dementia, to increase understanding of the condition and to support and help people seeking the development of dementia inclusive communities. So as I mentioned, family carers play a vital role. We know that people with dementia are high users of our health service. It's estimated that about 37% of home care is provided for people with dementia, and at least 30% of older people are admitted to our acute hospitals with dementia. They have longer hospital stays and unfortunately have a higher risk of mortality while in that setting. A high proportion of people in residential care are also living with dementia. And the main bulk of dementia care, as I mentioned, is provided by family carers, and they're often the most important resource for people with dementia, and they really shouldn't be overlooked in terms of that importance. Family carers continue to play a role with people with dementia even when they're admitted to hospital or when they go into long-term residential care. And while it's difficult to place a monetary value around family caregiving, the WHO does estimate that 50% of the global cost of dementia is attributed to informal care. So I know that speakers later this afternoon will present on the caregiving role and consider the gendered nature of that caring. Family caring is different depending on a number of factors. For example, the relationship between the person with dementia and the carer, or sometimes the physical, social and support environment that the carer is living in. So services such as daycare, home care and restorative care through respite can support family carers to continue in their caregiving role. COVID-19, it's very important that we highlight the challenges that carers and people with dementia have experienced as a result of COVID, and many formal supports had to pause throughout that initial COVID period. Thankfully, we are seeing progress with phased opening of day services. However, there is an impact to that pause on people with dementia and also the people that were caring for them and their families. Health policy is to support people to live at home as long as possible, and as the A&D for services for older people change and innovation, my whole focus is reforming services for older people to enable people to live at home for as long as possible. And my brief, as I mentioned, covers dementia as well. And separate to that, even across all of our broad spectrum of service delivery, the focus is to enable people to live in their home setting for as long as possible, with the supports going in to assist people and their families to do that. Through our national service plan, we've funded a number of organisations such as the Alzheimer's Society of Ireland, and through that we're continuing to provide day care at home, particularly important when day services were closed during the COVID period, and it did provide much needed respite for families. We now have national dementia advisor services operating across the country, and they offer information, advice, signposting, and also emotional support to people throughout the process, quite often supporting carers directly. So in addition to this, we have a network of memory technology resource rooms that support family carers through the provision of advice and assistance and assistive technology, and also giving practical day-to-day advice on management and coping. So in terms of the plan for the future of dementia care, we have to, as I mentioned in the outset, continue to be focused to striving to improve dementia services. So as part of that, we're looking at finalising the dementia model of care. That's built around available evidence, consultation with key interest groups and stakeholders, and that includes people living with dementia and their family carers. So the National Dementia Office have met recently with the Irish Dementia Working Group and the Dementia's Carers Campaign Network as part of the consultation for the model of care. And this is to ensure that the voice of carers and families and people with dementia are heard when we're developing this important model of care. Public consultation for the model has recently completed, and the National Dementia Office is working on redrafting the model for publication very shortly. So in closing, once again, many thanks for inviting me to open this important policy and practice forum. I believe that this forum will help raise an awareness and identify key considerations for formal service providers when engaging with families. I think it will also highlight how gender issues are impacting on our care provision, including care planning and also advanced decision making. I hope you all enjoy the afternoon's discussions, and I look forward to getting an update on how the event went on. And I just want to take an opportunity to thank the organisers of the event. So in particular, Carol Rogan from the DRNI and also Emer Begley from the National Dementia Office. And I think just to close, there's a quote I often use, and I think it's very apt for today. Coming together is the beginning. Keeping together is progress, and working together is a success. And to be fair, as the second annual forum, I think it's testament that this group is beginning to work together and will continue to work together to bring forward great things for people with dementia and their family and carers. So thank you very much for inviting me today.
Thanks very much, Jeanette. Thanks for your time today, and we look forward to sharing the report with you when it's available, the report from today.
Thank you.
Okay, so we're now going to move on to the next section of the forum, which is we're going to look at family care landscape through a gender lens. So our first speaker is Dr. Nikki Dunn, who's a research officer with Family Carers Ireland. So over to you, Nikki.
That's great. Thanks, Carol. So just to introduce myself very quickly. So my name is Nikki Dunn, and I'm the research officer with Family Carers Ireland. And what I'm going to do over the next 10 minutes is really just set the scene, I hope, for the rest of the afternoon with regards to caring, dementia and care and gender. I'm going to briefly reflect on carer prevalence in Ireland, before focusing in on some findings from a couple of studies that Family Carers Ireland have been involved with, just to kind of pull out some of the impacts on family carers and specifically on family carers of people living with dementia as well. So in terms of who cares, what do we know about carers in Ireland at the moment? So according to the Irish Health Survey in 2019, there's approximately 1 in 8 adults who are providing care. That roughly equates to approximately 500,000 family carers across Ireland. We also know that the typical family carer is a woman. The Irish Health Survey shows that 14% of women across Ireland provide care. That's not to say that men don't care. There's 11% of men within that population as well. But women are more likely to take on care and responsibilities, and in the Irish Health Survey and the census shows that women are more likely to provide more hours of care as well. Now, if we drill down into people caring for a person living with dementia across Ireland, Jeanette has mentioned already, there's approximately 64,000 people diagnosed with dementia in Ireland, and for every one person diagnosed, 3 other family members can be significantly affected. And there's estimated 60,000 carers providing care to people living with dementia in the community. And in a study profiling dementia family carers, approximately 73% of carers were women. So again, some of those kind of gender norms coming through there in terms of who is doing the caring. So given the importance of families and supporting people with dementia to live at home, it's important to pay attention to them, and it's also really important to understand how care responsibilities might affect them as well. So I'm just going to refer very briefly to a piece of research that Family Carers Ireland were involved in in collaboration with UCD and the College of Psychiatrists in 2019. And these are just some of the impacts that we found from that study. So 67% of carers reported they were diagnosed or treated for a physical health condition. Almost 50% reported that they were diagnosed with anxiety and/or depression. There were really high rates of stress, isolation and burden amongst the people who responded as well. And over 2/3 of people reported that they felt that their health had been impacted as a result of their caring role. We also conducted a piece of research in early 2020, just before the pandemic hit Ireland. And again, this is quite consistent with the research literature showing that caring can have an impact on multiple parts of a carer's life. It's not only necessarily to do with health and well-being. I won't spend too much time on methods here, but in a nutshell, the state of care and research is a snapshot of what it's like to care in Ireland at a specific point in time, and it's run every 2 years. So the next one will be taking place in January 2022. Over 1,200 people responded to it, and 11% of those carers were caring for a person living with dementia. 85% were women, and the average age was 52, and there's quite intense level of caring going on there as well. So 74% reported that they were caring for over 90 hours a week, and over half were caring 140 to 168 hours a week. So round the clock caring, and then most carers within the sample as well were caring between 1 and 9 years. Now, one of the issues that we wanted to explore in this study was about how carers were coping financially. We know that for many carers, taking on caring responsibilities can result in long-term financial hardship. The loss of income is often that comes from a loss of employment or having to reduce working hours, at the same time as higher household bills can, as a result of caring, made us really aware and want to kind of build the evidence base around the financial impacts of caring. So when we asked the respondents, and sorry, I'm speaking, the rest of the results here are speaking specifically to the dementia carers sample. So that 11% of the 1,200. So when we asked carers about their ability to cope financially, 59% of carers of people living with dementia found it hard to make ends meet, and 17% could only make ends meet with great difficulty. Over half said that they'd been in debt or were likely to experience it in the future, and 40% were spending more than €150 per month from their own pocket on additional expenses associated with care, and that's like travel, personal care products, utility bills, and so on. And we found it particularly concerning, and this is the same across the general carer sample. 1 in 5 of those who said that they were struggling financially, they were finding it hard to make ends meet, were cutting back on essentials such as food or heat in order to make ends meet. And you can see actually in the next comment here, this woman here she obviously had to, she was because of the costs of diesel, medication, anything that wasn't covered by the medical card, she was and the requirement to pay in care for a day, she was having to put aside her own health and her own health appointments because she couldn't afford it. And that the financial strain was palpable in comments across the survey amongst the general carer population and the dementia carers. This was a significant issue amongst the people who responded to the survey, and it really does suggest that many caring households are at risk of poverty. You know, like when you think about nearly 60% are finding it hard to make ends meet. Now, in terms of the impact on employment, so nearly half of carers of people living with dementia said that they'd left the labour market to care. Others had tended to reduce their working hours or had turned down career training or educational opportunities in order to reconcile employment with their caring role, but many just were not able to reconcile. They weren't able to actually marry up the two roles, and that did result in a lot of people leaving the labour market. And you can just see kind of the stress here and the impact through this quote, the impact on this person's career progression. They weren't able to actually take up the opportunities that might have been there if they had been supported in their caring role, or if they hadn't been so stressed. Now, there's long-term implications here that I think are quite gendered as well. The state pension system here in Ireland measures contributions in terms of PRSI, and the enormous contribution that is made by carers isn't recognised or used by the state when it comes to calculating pensions. So the immense contribution of carers, as Jeanette mentioned earlier on, like it amounts to billions, and estimates in Ireland are up to 20 billion. The contribution of family carers in terms of the hours that they work, and this isn't seen as a contribution when it comes to pensions. It's not recognised, and it is a gendered issue in that it affects long-term carers, people who are caring for really long periods of time, and the majority of them are women. And not to say that it doesn't affect men, of course, as well, because it will do. Now, the programme for government has made a statement that they will address that pension anomaly and try to recognise carers and their contribution. So hopefully this will change over time, and the Pension Commission report has gone to Minister Humphreys. So we are hopeful that this will change. So I'm going to leave it there now. I think Zoe is going to pick up on some of the more gendered kind of implications and stigma and inequities. I'm happy to answer any questions that anyone has. And the State of Care report, it does refer more so to the general carer population, but that's on our website there, along with the other reports there, if anyone is interested in finding out more. Okay, thank you.
Thanks very much, Nikki, for giving us some data there and setting the context for family carers, and also the impact. You can see it's quite stark in terms of some of the impacts for family carers. So our next speaker is Zoe Hughes, who's Senior Policy and Research Officer with Care Alliance Ireland. So I'll hand over to you, Zoe.
So as Nikki said, I'm going to speak a little bit more about, I suppose, some of the broader gender theory parts, I suppose, and how it might impact upon caring, and some. Again, I'm a terrible person. I very much like asking questions, maybe sometimes more than answering them, which doesn't make for a particularly effective researcher sometimes, but a very enthusiastic one at least. I suppose from the historical perspective, you know, caring is very much seen as a feminized activity. And what does that mean? I mean, caring has been seen and positioned as women's work over time. And it's very clear to see that through various bits of research. And even if you just look at the history of Ireland and also other countries as well, it's not a uniquely Irish phenomenon. But from our very gendered constitution and upwards from there, you can see the impact of it. In fact, the modern carers movement really began to as a way to have women's care work recognised, and because of this feminization of care work in general, and in care work I also mean paid care work, but also care work in the home. Care work has been devalued, so there's low pay if pay is something that happens at all. A low social value kind of attached to care work, and so this is going to have impacts on how care is supported throughout society, really. And from that, then, because of this devaluation of the feminization of care work, those male carers who do partake in this work and who do act as a family carer or as a paid carer, but in particular a family carer, that kind of care work is stigmatized as being maybe weak or feminine, and those are negative traits that are often kind of positioned as when you look at maybe a patriarchal society or one that's very kind of into more productivity. The idea of not, you know, having the strong male breadwinner doing the breadwinning and doing the care work instead is stigmatized. And there are some reports of young male carers in particular experiencing, I suppose, a form of homophobia, regardless of their sexuality. So if you look at what that means is that regardless of a young teenager, maybe a young man growing up, if he's involved in care work for somebody within his family, he's called gay, he might be stigmatized for that work because it's not seen as something that boys or men do. And that has a real impact going forward on the types of supports that male carers may actually access. So speaking a little bit to the identity of what a carer is. So in general, I think a lot of people here on part of this today will understand that many carers don't identify as a carer. And so by that means you sort of, rather than saying, yes, I'm a carer, it's like, well, I provide care for someone I love. That's not really being a carer. That's just being a family member. That's being a husband, a wife, a father, a son, a grandparent, a grandson, whatever that might be. But when it comes to looking at men in particular, relatively few men in these types of roles identify as a carer to access support. So what that means is they focus much more on the skills and the tasks that are involved rather than the identity of being a carer. And there's a kind of a really great paper by Molyneux, which is in the references that I'll have at the end of this. And it sort of says that the identification of being self-identification as a carer is the gateway through which supports are accessed. And I think that's a really good way of looking at it, is that for very often you have to say, yes, I'm a carer. You have to stand up and recognize that you are a carer yourself in order to get the supports maybe that will help you within any difficulties and challenges you might actually experience as a family carer. If you look then at what kinds of supports men generally prefer, there is the idea of side-to-side support versus face-to-face support. And an example of this I think is really useful to think of when it comes to family care in particular is West Cork Carers, which are a group that sadly have had to pause and don't actually exist anymore, did a support group specifically for male carers where they chartered a sailboat down in West Cork, which frankly sounds idyllic, but that's neither here nor there. And actually the part of the supports was actually that the male carers learned about sailing and learned to pilot the sailboat. And that's the kind of side-to-side, side-to-side supports where they're focused on a task that's not related to caring, but naturally, because that's what they all have in common, then the peer support kind of comes up that kind of side to side, versus face-to-face supports, which traditionally women appreciate a bit more. So going to, for example, a peer support group, a coffee morning, whatever it might be. Now, obviously, I'm not saying that that is how all men and all women access supports and like to be supported, but that's just a generalization that I think is useful to think about. But I suppose what I'd like to as well highlight is this can be changing. So Anne Stokes did her PhD, I think I have the date wrong there, so that should be 2015, so they show that there's resistance to that traditional masculinity, if you know what I mean, and when it comes to caring. So that a lot of men now are kind of resisting that idea that it's weak to be a carer, that it actually, you know, that you shouldn't be emotional, you shouldn't be in this role. And we can see that throughout society, but it's taking, I think, a little bit longer for that to filter through, perhaps in caring supports. And I think what I'm about, this slide is one that I have sort of provided a few times, and I think actually that it might be slightly contradicted by another by Maria's presentation, which is actually really good, because that's one of the things that you kind of go, let's have a chat about, you know, why in some areas are male carers less likely to seek supports? Are they less likely to accept help when they're offered? More likely to feel uncomfortable at carer groups? More likely to feel stigmatized? And less likely to have understanding employers? And there's lots of reasons for those that I don't have time to speak about here. But I think it would be really interesting to hear from Maria and have a discussion about it at some point, perhaps not today, but at a later stage. Kind of not quite finishing up, but one of the last points I wanted to make was around trans and non-binary caring. I think it's extremely remiss, if we're talking about gender and family care, to stick purely to the binary of gender. And so if you think about trans and non-binary communities, really are disrupting traditional notions of gender across the board, not just in caring, but obviously within caring, it's kind of, you know, the idea, if you're non-binary or if you're trans, then that kind of gender binary of male carers need this, female carers need that, doesn't really make much sense. So, you know, can or should we really create binary understandings of care anymore? And by binary understandings, I mean gender binary understandings of care. Like I said, you know, this is for men, this is for women, and maybe never the twain shall meet. But is it more useful perhaps to think about masculinity and femininity in care versus male and female care? So for example, if you think about, and I know I'll be part of the panel on LGBT caring in dementia in a few minutes. But I think, for example, if you have a butch woman who's caring versus a femme gay man who's caring, you know, what are the consistencies there? What are the overlaps? What are the commonalities, and what are the differences? And I think it's very interesting to look at that in some way. And I really appreciate that this is not specifically around dementia, but perhaps we can talk a little bit more about that in the LGBT panel in a few moments. Just to finish up, I wanted to highlight some of the recommendations that came from the Citizens Assembly on gender equality a couple of months ago that are specific to gender and care. There's three really that I kind of picked out. So the first recommendation I think is really useful to think about and might help us actually situate some of our discussion is that the Article 41.2, which is around the woman's place in the home of the Constitution, should be deleted and replaced with language that is not gender specific and obliges the state to take reasonable measures to support care within the home and the wider community. And I think that's really important to see that it's not necessarily binary in any way, that's not gender specific, but just recognizes the actual work of caring. However, there is also a need that the Citizens Assembly recommended to make special efforts to improve the visibility of men performing caring roles, and then also to adopt a fully individualized social protection system to reflect the diversity of today's lives and to promote an equal division of paid work and care. That was specifically really related to childcare, but I think it's applicable across the lifespan of caring. And I know there are a couple of organizations led by one family who are doing some work around trying to move forward these recommendations and put them into policy and legislation. And we in Family Cares Ireland, or not Family Care, I just saw Nikki's name and automatically read Family Cares Ireland, is Care Alliance Ireland are part of that. So apologies for that mental slip up there. And so these are my references here. So when you can have a look at some of these, and I would say that a lot of the points I make today are fleshed out a little bit more in the submission to the Citizens Assembly on Gender Equality that's up on our website. So I shall stop there. Thank you very much.
Thanks very much, Zoe. So lots of food for thought there, and Zoe will be joining the panel discussion as well in a little while. So I'll hand you over to our next speaker, who's Dr. Maria Pertl, and she's a lecturer in psychology in RCSI, and she's going to talk about a research project she was involved in called De-Stress.
Hello, everyone. I'm so delighted to take part in the forum today. So, as Carol said, I will be talking about some of the findings from the De-Stress study. And I suppose, first of all, it's important to point out that the distress study, the aim of the study was actually to look at, to examine the relationship between caregiver stress and cognitive functioning. So we weren't actually specifically asking any questions related to caregiving and gender, but we did ask a lot of questions that are relevant to the forum today. So specifically, we collected information on physical health and psychological well-being, service use and support for caregiving as well. We looked at some of the differences in terms of men and women, male and female caregivers on these factors. So in terms of health and well-being and caregiver supports as well. So a bit like Zoe today, I think I'm going to raise more issues for discussion and ask more questions than give you any answers. But I'm going to present some of the data that we have on the differences in terms of male and female caregivers on these factors. So just to give you a kind of a brief idea of the study and who took part, this was the largest study of spousal dementia caregivers in Ireland. So anyone who was over the age of 50 and was cohabiting with a spouse or partner with dementia was eligible to take part. And we recruited through lots of different media, community gatekeepers, service providers, mainly the Alzheimer's Society of Ireland, and also through local advertisements and various different organisations. Altogether, over 500 caregivers expressed an interest in taking part, and our final sample consisted of 252 caregivers who took part in the baseline survey, and then there was over 200 in the follow-up as well. To give you a brief idea of the sample characteristics, the majority of caregivers were female, and this is very much in line with the literature. Again, as previous speakers have said, where it's very well documented that the majority of caregivers are women. Maybe in our sample, we had actually slightly more males than is generally represented. In terms of age range, very wide from 50 to 90, the mean age was just shy of 70 years of age. But there was a substantial proportion of caregivers who were actually above 80 years old. They were quite an educated sample, and only about 16% of caregivers were still in full or part-time employment. And in terms of the length of care, so again, this varied hugely between the participants, so ranged from 1 month to 19 years, but on average, caregivers were caring for about 5 years. So the majority, so about a third of the sample have been providing care for 5 years. So before I talk about gender differences in terms of health and well-being, I just want to focus on 3 key points from De-Stress, just to highlight some key findings from the study in the overall sample. And the first is really that the level of care provided by these spousal caregivers was extremely high. So the overall amount of care was very high in general, and regardless of gender. And on average, participants reported that they spent about 12 hours a day providing care, and a substantial number provided 15 hours of care a day, and nearly half reported that it was 24-hour care. So really very, very high level of care. Secondly, the assistance with caregiving was very low. So about half the participants were the sole caregivers for their spouse or partner with dementia, and a further 20% reported that there was one additional person who was assisting them with care. So really, most of the care fell to them. And nearly 80% of the sample said that they provided 81 to 100% of the care for their spouse or partner. So really, it was mainly falling to them. And then finally, when we asked caregivers about their own mental health, most of them reported that it was very good. So nearly 80% said their emotional or mental health was good or better. But actually, when we assessed for depression and anxiety, we found a very high prevalence of this. So 1 in 3 caregivers had significant levels of depression, 1 in 5 had significant levels of anxiety, and 45% reported moderate to severe levels of burden. So overall, this was a sample where participants provided a very high level of care, where they had quite a low amount of help from other people. So both in terms of help from service providers and from family and friends, and where a substantial number experienced poor mental health and high levels of burden. So bearing that in mind, let's look at the gender differences then. So yes, as Zoe said, the findings from de-stress seem to contradict some of what's in the literature in terms of gender differences. So we actually found that male caregivers overall had much better well-being and greater support than female caregivers. So in terms of the supports that they received, men were far more likely to or women, sorry, were far more likely to provide that very high level of support. So they were far more likely to provide 80 to 100% of all care needs. This is in line with the literature that suggests that women are more likely to provide more hours of care, so that more intensive level of care. Men also used a greater number of support services like respite care and daycare than women. So they had greater access or made greater use of these services, and they were also far more likely to receive help from family or friends in terms of caregiving tasks over the past 30 days. Interestingly, they also reported greater self-efficacy, so they had greater confidence than women in terms of accessing support services and greater confidence in terms of managing symptoms, like symptoms of dementia, such as responsive behaviours. And they consistently had better psychological well-being than female caregivers as well. So they reported lower levels of depression, anxiety, burden and stress. And they also had lower levels of loneliness, even though female caregivers actually reported higher levels of social connectedness. So there's that distinction there between loneliness and social connectedness. And then finally, male caregivers also reported greater overall life satisfaction and quality of life. And they also identified more positive aspects associated with care. So these are things like opportunities for personal growth or connection or learning new skills. So what does this mean? So again, because the study wasn't set up to explore these issues, I'm just reporting essentially on the gender differences that we found, but I don't have the answers as to why this pattern of results emerged from the study. But I'm going to put forward some explanations, and then I'm really interested in hearing your thoughts and opinions about why these findings emerged. So if we consider first why might male caregivers have greater supports for dementia care? Why might we have found this in the study? Well, first of all, it's possible that because of the nature of our sample. So we recruited to a large extent through support services and gatekeepers. So it's possible that more men who were already linked in with services volunteered to take part. Now, you might say, well, that would equally apply to women, but we also recruited through community newsletters and the media and so on. So it's possible perhaps that women are more likely to volunteer when they read about it in the newspaper than men who might be more likely to volunteer if they're actually directly approached by somebody who they trust and work with already. So that's one explanation. But I think another factor that we definitely need to consider is the socialization of women as carers. So it's possible that women are just less likely to actually ask for help for caregiving supports, and asking for help for caregiving tasks might actually be more stigmatized for women than for men, possibly because there's an expectation that they're meant to be able to do everything and to provide this type of care, whereas it's not seen as the norm for men. And that may also mean that women are less likely to actually be offered support, because possibly there's an assumption there that women are able to perform these tasks or should be able to perform them. I thought it was interesting as well that the lower level of support was reflected in both caregiving supports from service providers and from supports from family and friends. So that was lower for women, both the service provider supports and family support. So the next question then is, why might female caregivers have poor mental health? So again, this could be due to the nature of the sample or perhaps a reporting factor. So we know that the prevalence of anxiety and depression is higher among women in the general population, and reporting mental health issues might be more stigmatized among men than women. So that's one possible explanation. But then in our sample, the intensity of care provided by women and their use of support services was also much lower than men. So they had provided greater care, and their support service use was lower. So that could contribute to greater levels of burden and stress, and then obviously that may impact on mental health as well. Women may also be more affected by reduced opportunities for social interaction following from providing dementia care. So they definitely in this sample reported greater levels of loneliness, and that would support that as well. So that could have an impact on mental health. And then another possible explanation is differences in coping approaches between men and women as well. So there's some research evidence to suggest that women might be more likely to use emotion-focused coping strategies compared to male caregivers or the general population even, and that has been linked to poor psychological well-being. And some research also suggests that different approaches to caregiving may explain gender differences in psychological outcomes. So there's some data to suggest that women might be more likely to attempt numerous caregiving tasks simultaneously, and men are more likely to take on fewer tasks initially and to work through them in a more sequential manner. So to do one thing at a time, and that may leave more time for rest and doing non-caregiving activities. It's interesting as well that we found this difference in confidence, both in terms of accessing care supports and also in terms of symptom management. And confidence or self-efficacy could definitely feed into psychological well-being as well, whether you think you're able to do something or not, or how good a job you think you're doing of something. And then finally, the other thing thrown up by the data as well was the differences in sleep quality. So male caregivers reported better sleep or less sleep disturbance than female caregivers. And we know that sleep and mental health, sleep is a key factor for mental health as well. So, and that could possibly tie into emotion-focused coping as well, with rumination and sleep disturbances as well. The final question I kind of want to put to you is, what are the implications of this for health and social care practice? So how do we interact with and support male and female caregivers? And does gender impact on how we deliver care and how they can access care? And I think this is a really important point for reflection, because it's something that we might do subconsciously. And given the differences in the sample and the fact that this was really across the board in terms of health and wellbeing factors and support service use, I think it's really important to highlight the need for a holistic approach in order to support caregivers. So it's not just focusing on giving tangible support for caregiving tasks, but we also have to consider mental health needs, impact on sleep quality, what their confidence is like in terms of accessing supports and managing symptoms, and opportunities for social engagement and connection as well. And bearing in mind that the needs might actually be different for men and for women. So I'm going to leave it at that, and I hope that we have a bit of time for discussion, if not now, then after the presentations. Thank you very much.
Thanks very much, Maria. That was very interesting findings. And actually, there's a question there. I might leave you to answer that in the Q&A, because we need to keep moving on. So I'm going to hand you over now to Dr. Emer Begley, who's the Interim General Manager for the National Dementia Office. And Emer is going to facilitate our panel discussion.
Thanks so much, Carol, and good afternoon, everyone. I'm going to invite the panelists to join with their videos and sound now. So taking some of those themes that Paddy talked about. The next part of the forum is going to look specifically at LGBTQI plus community and dementia care. We have a great panel of experts who are going to flag, I suppose, taking that theme of asking kind of more questions and raising issues than maybe having all the answers. But really what the discussion this afternoon is really about is to kind of start a national conversation on issues that affect the LGBTQI plus community in relation to dementia care and family caregiving. So I'm going to invite each of the panelists just to say who you are and where you're from, and maybe just reflect a little bit on what your specific area of interest is in this space, and also maybe where your expertise lies as well. And then I'll pose questions to each of you after that. So we'll start in terms of my screen. The first person I see there is Zoe.
Hello, everybody again. My name is Zoe Hughes. I'm the Senior Policy and Research Officer with Care Alliance Ireland. My interest, I suppose, in this area is I'm a member of the LGBT community myself. I've been a carer in the past, and I'm sure I will be in the future. And I'm also doing my PhD, my doctorate in applied social studies in UCC. And my topic for my thesis is the support needs and experiences of carers who are part of the LGBT community. So that's me in a nutshell, I suppose.
Thanks so much, Zoe. And nice to have you join us in the panel after a great presentation earlier. So thank you. Next up, I have Lorna.
Thanks so much, Emer. So my name is Lorna Rowe. I'm a research assistant professor in the Centre for Health Policy Management in Trinity College Dublin. I specialise in health services research, particularly focused on the care for older people. In June 2019, I co-led a workshop which attempted to explore the lived experience of older LGBT plus people in Ireland, their experiences of ageing, healthcare, and ability to age in place. This was part of a fellowship I did at the Global Brain Health Institute. So my views today in terms of the responses I'm going to give are really informed by the workshop participants and people that are living the experience in Ireland as such, and also from my reading of the wider literature. And thank you so much for the invitation to be here.
It's lovely to have you join. I know Lorna from many years ago when we worked in Age Action, so it's lovely to be on a panel with you again, Lorna. And next up, I have Miriam.
Hi, everybody. Hi, Emer. Thank you. So my name is Miriam Galvin. I'm a professor of research methodology in Trinity. That's my academic side. I work a lot with caregivers in neurodegeneration, and a lot of the work that what was spoken about before resonates with me and the work I've done in terms of things like stress and burden, but also positive aspects, I think is something we need to think about as well. And perhaps, the caring relationship itself and how it develops and the good things. And I think Paddy alluded to it there, and Derek and Paddy experience. So my interest in and why I hope to contribute here, or certainly listen and learn more, is I'm interested in masculinities, discourse, and intersectionality. So gender theory kind of per se, and then I just ally that with my caregiving kind of research. So that's where I'm at. And I was part of that workshop that Lorna referred to earlier in 2019, listening to LGBT and older people. Thank you.
Thanks, Miriam, and thanks for joining us as well. And next up, I have Sinead.
Hi, thanks for having me. My name is Sinead Hines. I'm a lecturer in occupational therapy in NUI Galway. I'm also an occupational therapist. So my research is with people with dementia and family carers, particularly people living in the community and kind of trying to maintain community independence. I also have a research interest in MS as well. In particular to this research, I'm leading some research in conjunction with the Alzheimer's Society around identifying the future needs of older people from the LGBTQI plus community in relation to dementia care in particular, but also kind of more broadly. That research is very much informed by and kind of led by PPI, or public and patient involvement, so particularly older people from the LGBT community. Thanks for having me today.
Thanks so much, Sinead. And when we were putting together the panel, we were really looking for researchers, a mix of researchers and with lived experience, and also those that can represent advocacy groups. But what we did notice was that there wasn't a huge amount of research in this space, which is very interesting in itself. So it's great to see the work that you're doing. And finally, Kieran.
Hello, folks. So I'm Kieran McKinney. I work at Age and Opportunity. I manage the Engage program. I've had the pleasure of at least collaborating with Zoe and Lorna in the past, and you, Emer. And I'm here as a member of the LGBTIQ+ community. I've been involved in, well, what I refer to as gay activism in the late 70s, and it has now, thankfully, become more inclusive of trans, bisexual, lesbians, and indeed intersex people, etc. So I'm delighted to be here. So.
Thanks so much, Kieran. So we obviously have a very expert panel, which is great. And so there should be robust discussion and flagging of key issues. So the first question I want to pose to you all is that some health and social care professionals believe that operating a sexuality blind service means greater equality. And I just want to get a sense from you all about what are the positives and negatives of taking that approach, particularly for people with dementia and for their family carers who are supporting them. So I'll open it up to whoever wants to jump in first. And if any of you want to follow up on what somebody said, please do. So who wants to? Lorna, go ahead.
I was saying to Carol that I had a more lengthy response to this one, so I might just get it out of the way while I can now. So in attempting to address this question, my answer really is coming from the perspective of addressing health inequities. And these are defined as differences in health that are systematic, socially produced and unfair. So a 2018 systematic review on the theme of LGBT+ and aging found that LGBT+ people are more likely to carry a greater health burden in older years relative to their heterosexual peers. And these inequities are thought to result from the history of living with stigmatization, discrimination and oppression, which is associated with poor physical health, disability, chronic disease, depression and old age. But health inequities may also be perpetuated in old age again. So for LGBT older people will report becoming doubly invisible as they age because they may experience age discrimination from within their own youth-oriented culture or community, and age and gender or sexuality discrimination from society more generally. And there's also some evidence to suggest that older LGBT+ people may face distinct risk factors related to cognitive impairment and dementia, including social isolation, discrimination, barriers to care access, limited availability of and support for caregivers, and higher rates of certain chronic diseases. So while many of these factors that are driving health inequities exist or factors that are outside of the health system itself plays a vital role in addressing health inequities and supporting healthy aging by addressing modifiable risk factors for diseases such as dementia, and of course, providing care and support to people living with chronic illnesses as Paddy described. So the question really is, how can health systems address the specific needs of this community? And in trying to think about it, the way I thought about it is it doesn't make sense, or it's not possible or feasible for health systems to create a plethora of LGBT specific services. And this really comes from my own background looking at older adults with complex needs. So many LGBT+ people, like heterosexual peers, will live with many different types of health problems, requiring inputs from across the services. So GPs, public health nurses, allied healthcare professionals, hospital doctors, home care workers, to name but a few. However, equally, I don't think that health systems should be blind to the needs of LGBT older adults, as health systems really are a microcosm of society at large. And this approach will reproduce existing social structures and behaviours. And from the workshop, we can see that this is happening today. We can see in the policy and systems landscape which older LGBT+ people are aging within today from the workshop participants. For example, we know that older LGBT+ community groups are not able to access the traditional financial supports which are available to communities who are more typically defined by geography. We know that many older LGBT+ people may not have access to family carers to help them in old age. And of course, the system of care that we have is for state provided home help to provide something that supplements care. It's not enough on its own to sustain a person at home. We know that staff are not typically trained to provide culturally competent care for older LGBT+ people. And older LGBT+ people both experience and are very fearful of derogatory or stigmatizing comments from other staff and service users. And this may actually stop them from preventing help or engaging with services. And finally, we know that, and I think Emer touched on this, we know that LGBT older people have not to date been identified in research in Ireland. And this really means that clinicians don't have evidence specific to the LGBT+ population on which to design services. but also that policymakers are blind to LGBT-specific barriers to care and estimates of costs of care for LGBT plus people. And these are really just a small number of ways that I have to illustrate how health services being sexuality or gender blind really negatively impacts on older adults living with dementia and their carers. And while I feel it's necessary to take kind of a health equities perspective to understand how systems need to change, and that system right across from culture, behaviours and attitudes of staff, right through to policies, services and supports. So I guess it's not a single intervention that's going to address this. Sorry, I've probably gone over my allocated time, but I feel I've got it all off my chest.
There's a huge amount of what you said, and I saw an awful lot of nodding heads. So does anybody else want to come in? Kieran?
So I think we can learn from the Black Lives Matter campaign, so that when people responded by saying all lives matter, well, in fact, what they were doing was denying the issue, which is that Black lives do matter. So if we have a blind policy, then in fact, we, and I'm speaking as, we of the LGBTI plus community, could very easily be completely ignored, because the societal standard, of course, is still the assumption that, firstly, that most people are heterosexual, but more importantly, that as we age, we are no longer sexual. So I think it's critical that we acknowledge, respect, support, value the fact that as older people, we still retain our sexuality, and then that gets expressed according to our sexual orientation. And then within all of that, there's the gender identity of people who have either, who have transitioned or indeed who are intersex. So it can't be blind, it has to be addressed specifically. So,
thanks, Kieran. And I think Zoe, you wanted to come in.
Yeah, no, absolutely. There was a really interesting study that I read. I seem to start most of my sentences with that recently. There's a really interesting study I read, but as part of getting to grips with this topic, and in Australia, it particularly came across that family carers in particular who identified as LGBT in some way were really put off by organizations that said, we don't discriminate, everybody gets the same service. And it's like, well, that's great, but some of the issues that I'm having that are related to the intersection between my caring and my sexuality and perhaps even my gender identity, while caring, the issues of caring for someone with dementia or caring at all will be, those issues are pretty much the same, like, in lots of ways. Then there's an additional impact for both positive and negative. Like, it's not all negative. I just wanted to stress that as well. There'll be a lot of positive aspects of being LGBT in when it comes to caring. But it's really important to see that and to kind of go, we can't just say, well, we see everybody equally, so therefore we're not actually going to talk about any specific issues, or we're not going to be comfortable raising them, or whatever it might be. And carers in particular seemed really off put by that. And I think that's a really important thing to note. And something else I wanted to note as well is that, I always, for example, when we think of dementia, and again, I'm not an expert in dementia by any stretch of the imagination, but I suppose something that comes across an awful lot and that has been spoken about in the literature and research is the idea that a lot of family carers won't necessarily want to come out, because to the person that they're caring for, if it's not a spouse or a partner, they may have to re-come out over and over and over again as part of their caring, and they really don't want to have to do that. You know what I mean? And but it's also to note that that's just something that I think is worth saying. So I'll stop there before I could ramble for ages about this, but that was just something I wanted to say on the topic.
Oh, it's a very good point, Zoe, so thank you. And Sinead or Miriam, do either of you want to come in? Sinead?
Yeah, I could come in there. I suppose I just kind of would agree with a lot of what everybody has said to date. I think it's a cop-out to say that, the service is sexually blind, is that the term that you use. It's we wouldn't use the same kind of term if we were talking about cognition or something like that. We don't say our services are cognitively blind. We adapt and we make sure the services are useful and specific to the people that need to use them. You know, if you're talking about sexuality, you're talking about partnership, activity, behavior, attitudes, function. So if you're neglecting all those areas, then you're neglecting a huge part of the person's life. And as Kieran said, you know, there's often these issues around as people age that and perhaps, and you know, particularly as well when you're talking about dementia care, that's seen as maybe not an issue, or you know, it's not something that people are interested in as they age. And I think there needs to be more of a focus, maybe rather than, you know, looking at the idea of it being the services being sexually blind. And I'd kind of echo what Zoe said as well around the need for people to be coming out, and that oftentimes the onus is put on the person to educate the healthcare professionals rather than the healthcare professionals themselves taking responsibility for actually educating themselves as they would with, you know, other areas of care. Thanks.
Thanks so much. Thanks so much, Sinead. And Miriam.
Hi, thank you. No, I agree with absolutely pretty much everything. I think I'm looking at it again, I'm not a dementia specific person, I'm more a caregiver per se, but I think also, I mean, any of our identities shape our experience. So, I mean, as an older person or a person with cognitive impairment, I mean, identity is almost taken away from the person as well, because there's a sense of loss in terms of their self-perception or other people's perception of them. And I think for a cohort of people such as the Stonewall generation or whatever we're dealing with now, who fought, were primary fighters and activists for recognition of their identity, I think it's a wonderful confluence of interest that this group showed us all, if you like, to a certain extent, how to claim their place in society. And yet that particular cohort is now reaching a place where automatically for all of us, it seems to be, not only is our sexuality disregarded, but our identity as a farmer or as a teacher or as a mother is also somehow, we're just people with dementia. So I think while I agree that the blindness is inequitable potentially, I also think that the recognition of the intersectionality, so the bits we learned about earlier about the women and the males, okay, so you have a male LGBT person or a female LGBT person. So you've also got the intersectionality of being socialized as a woman and other. So I think we have to, I know we can't have a panacea for everything, but I think the acknowledgement of diversity is one thing. The need for cultural competence, the need for alternative decision-making, families of choice, all of those other things to be accepted, I think also might, as the LGBT or the Stonewall group did, it may also help other minority groups considered non-minority or non-normative within the society also to claim a place. That person-centeredness of itself is supposedly the person's at the center. So if we can see it through the lens of the LGBT group and who are fighting for this, I just think it can bring us to all other sorts of people who may find their needs not equally respected because they're, so I just think it's a wonderful opportunity to perhaps kind of find out what is useful for this particular community from those people. So I know the question was the second, what do people want, would be the second question or something. Well, I don't know, because I'm going to have to ask them, you know. So I think we have to really kind of bear that in mind as well. That's just my 2 pence worth.
Yeah, and Kieran, you wanted to come back in. Thank you, Miriam.
So Miriam, you know, thank you for like raising that issue. What do we want? And I would like to suggest that what we want most is acknowledgement that we exist. But this isn't just about being LGBTI. This is about, as an older person, my sexuality is still a part of me. And I think in many care services, that just vanishes because it's not recognized for older people at all. So I think there's a very basic level of challenging the ageist perception, yes, that as older people, we suddenly just don't have a sexuality, let alone a sexual orientation or indeed a gender identity. And then moving on from that, basically an acknowledgement that, you know, yeah, I have a past, I have a history. I might have a partner, I might not. Sadly, right now I don't, but you never know. Hope springs eternal. So, you know, but that if I have a partner, it will be a man, and that he then gets, you know, gets acknowledged as such, you know, and yeah.
And I wonder, Kieran, to you, like, I think the absence of the presence of LGBT data, for example, in policy making. I mean, just the absence of its presence speaks volumes. Like Lorna mentioned as well. I think in terms of data intake forms or just the general stuff. We can't actually. How do we keep track? How do people monitor from a research perspective? Sorry, that's me. What's going on if we don't name it for what it is. And the heterosexist assumptions that are there, absolutely, Kieran, I will absolutely, I agree with you. But it's also the more macro level, like as we said, sexuality is an essence of people anyway, regardless. And I think these are kind of global issues, but they find a lens through the LGBT community. And I think it's a very good place if the group and the community, if we can homogenize it for a minute, are willing to allow the rest of us who are not part of that community to learn from that community how to address other inequalities and inequities in the services.
But Miriam, we're all part of that community that as we get older, we still have a sexuality.
I'm with you on that, absolutely.
So we have a really basic shared platform.
I agree with you, absolutely.
Thanks so much. And I think when you bring in the whole dementia aspect as well, it's the identity for people with dementia where they're labeled as having dementia and that becomes their sole identity. I think, Zoe, you had your hand up there as well.
I did, and it ties into what to that part of it, Emer. I think as well, it's really important to notice that sexuality is not just about who you fancy. Like, it's not just about that. It's a lot more than that. And the thing that always strikes me in is like, for example, I mean, I'm very much a butch woman, that kind of a way. And the thought of having dementia and going into a nursing home, for example, where I get dressed up in very feminine clothes it's horrifying to me. You know what I mean? Because that's part of my sexuality also, and that's part of my essence as a human being. So, and I think that there have been reports in the literature of that type of thing happening, where it's kind of, there's a normative style that people are put into, and I'm talking about clothes. It seems very frivolous, but it's not. It's part of who you are. And I think anybody here would kind of go, I don't necessarily want to be put into tracksuits and, whatever it is, because it's easy for the caregivers, for example. Like, that's not part of that. And I think it's really important to notice that sexuality is not just about who you are attracted to. It again, like everybody else's sexuality, it filters into lots of different areas, and particularly around dementia. I think that there's those kind of added issues around being put into little boxes and the whole self not necessarily being understood. That was just a kind of a little aside there.
No, I think that whole self piece is so important, and we see it a lot in the dementia literature as well, about the maintenance of self and self-identity. I don't know, Sinead, did you want to jump in again?
I suppose it's just around like the making sure that anything that we're doing, we're planning, we're saying, that idea of including the people themselves in any service delivery, decision making. That's where you're going to get the best service, the most effective service. And I suppose we are trying to do that in relation to identifying what some of the needs of the population groups are. But yeah, no, I would agree with everything that the panel has been.
Could I be slightly controversial? It's not about that, Sinead, but in a lot of the literature you hear about inclusion, but there's affirmative pieces. That affirming goes beyond inclusion. It's kind of respecting and whatever. And I don't know in terms of how those models work, Sinead, because I'm not part of that, but is like when dementia inclusive, I've heard, and LGBT inclusive, it's sometimes I think it can be taken as we've ticked that box sort of thing, So I presume there's other bits along the way. I'm sure, I don't know, I'm not part of that space. Is that fair to say?
Yeah, I suppose I mean in relation to like public and patient involvement in planning, in service delivery. That's kind of what I mean, rather than
Okay, thank you.
Yeah, and you've all touched on it a little bit, and which is the second question I had is, well, what do people who are part of the LGBTQI plus community want from their health services, whether that's home supports or residential care or supported living? And you've touched on a lot of them already, and Sinead, just in relation to involvement in decision making, I think is a key piece. Just to go back maybe to Lorna, who started off the discussion, do you have any insights into to address that question?
I think it's very difficult. I think that when, from a research point of view, when we think about LGBT plus older people as a category or a target population that we're interested in, when I got into this area, I realized that, it's quite easy to think there's a common LGBT plus identity and set of preferences. And then when we did the workshop, you realize the complexity of the situation, because of course the variation exists between different sexualities and gender identities. And this then has knock-on effects for, you know, differing health behaviors, healthcare needs, healthcare outcomes, healthcare experiences. And of course, then there's very little evidence looking at the intersectionality of sexuality or gender identity and other factors such as ethnicity and socioeconomic background, etc. So there really is, we're so constrained in terms of what we don't know, that I will focus on what I learned from what people told me, which is basic principles around what care should look like. And I think some people have touched on this, that people want to feel safe, which is so fundamental. And it's shocking that they don't, or that they're worried that they won't. And there were so many different illustrations of that, and I've touched on some of those. But I think it's important to note that it's about changing staff behavior, but also about creating a culture within your service so that you don't experience discrimination or derogatory comments from other service users. So it's protecting people at both levels. And that again just came from the workshop participants. Again, the maintenance of identity is the age. I think there needs to be people talk about using correct pronouns. So that, you know, LGBT Champions program are doing really incredible work in training people to that end. And hopefully, you know, at another forum, we might hear them speak more about that. Miriam spoke about being inclusive of chosen family, as opposed to just this assumption that your biological family are the people that you want. And I think, you know, within the literature, there's also that assumption that the biological family is the person that would be involved in your care. By pursuing that can often lead to people disclosing their sexuality or gender identity when they may not have wanted to, because it's opening up a lot of those conversations. And then for people who do want to disclose their identity, I think it's been mentioned before, you know, just the effort of coming out over and over again to different staff, and how this can all be collected in a form. And we've made huge progress in terms of electronic forms with COVID. And so I presume all of these things can be implemented quite easily. And then visibility to policymakers and involvement within the research community. And that's both directing and also, so it's directing research, directing questions. And I think, you know, that's some of the engagement that we've had with some of the NGOs, including Kieran and others, has just been fantastic from that point of view as an approach to research. But also just looking at, like, we do need evidence looking at disparities in health, in addition to looking at, you know, the phenomenal strengths that this community have, that people have touched on, the resilience, the really strong social engagement and social ties, and looking at how to protect and also elevate that. So what we can learn from that other groups can learn. So they were some of the things that, you know, I felt coming more broad principles, I guess, rather than specific services and specific supports that people look at, because I think we're just not there yet.
Fantastic insights through that project you did, Lorna. I think, Kieran, I might invite you to give the last word as part of the forum, because I'm just looking at the time, and we're at 5 o'clock. So
Lorna, thank you so much for referencing the LGBT Ireland Champions program, because I was going to mention that as well. But there is also another resource, which is Being Me, BEING me.eu, and that was a European funded program, and it's quite a substantial resource around being an older LGBTI person receiving care in residential and daycare services. So I would, you know, recommend that anybody with an interest in this area goes there as well. There's some fantastic resources for caregivers. So
I think that's a great way to end the forum, the panel discussion. So thank Zoe and Kieran and Lauren, Sinead and Miriam for your time. And I think we could have a whole morning session on this issue alone. And I think you're right. Lorna said it's not a homogenous population among the LGBTQI plus community, and it's very nuanced and it's a dynamic space as well. So thank you so much. On behalf of Carol and the Dementia Research Network Ireland and the National Dementia Office, I am going to just say a few words to close the event. Thanks so much for all the speakers today. I think we've had a snapshot of issues that are related to gender, related to sexuality, and differences in caregiving. I think it's really important for us within the policy and practice space to reflect on how we involve and include a diversity of voices in the work we're doing. I think for health and social care professionals, the topics and issues raised today really shine a light on how we provide care to people and looking at what personalized, individualized care looks like, and how we deliver that in a way that involves the person in decision making as well. It's been a really stimulating afternoon, and I think when myself and Carol were talking about this with other experts in this space, what we really felt was that we're not going to be able to answer all the questions here. We might be raising more questions than ever addressing, but maybe it's given us all food for thought and maybe thinking about where we can go forward to address some of these things. And I think for the research attendees, maybe it's about also reflecting on the samples and the involvement and PPI and all of that has that diversity of voices. So on behalf of the NDO and the DRNI, just to thank you all. As Carol had said earlier, the afternoon session will be available on the DRNI YouTube channel, and there will be a formal report of the session's proceedings. So you can access that later in the year. I just want a special thank you to Manuela and Kim and Engaging Dementia for hosting us. And they've done a phenomenal job over the last three days. It's a big undertaking to do an online event like this. And thanks so much for hosting us again. And hopefully this won't be our last co-hosted event, Carol, and you might see us here again, or maybe in person even in 2022. Thanks for your attention, and enjoy your evening. So I'll say goodbye.